session on primary shoulder dislocation. My topic is a bit theoretical and boring, but I'll try to make it a little more interesting. So the reason we are talking about shoulder right now is because it is an inherently unstable joint, because it is statically unstable. The ligament capsule support is also anatomically variable, and there is a lot of dependence on dynamic stability. And that's why level of inherent stability in every shoulder is different. Every dislocated shoulder creates a pathology. And the MRI has given us so many names. There can be labral tear injuries, there can be capsular injuries, there can be bony injuries, and even in labral there can be undisplaced tears. There are tears with the periosteum involvement, there are displaced tears, and there are rotator cuff injuries, the articular cartilage injuries, slap lesions. All this creates a lot of confusion. And if you see that all these pathologies, most of them are investigative pathology, and mostly MRI and sometimes CT scan. So does that mean that we have to investigate every dislocated shoulder? So there are certain prognostic factors. One is the age. The younger the age group, more extensive the trauma, and these are more irreducible labral lesions. In elderly age group, there can be rotator cuff injury, and in a massive rotator cuff tear, the incidence of recurrence is more. Then there is a force of dislocation. If there is a hyperabduction with an impaction force, there is usually a large labral lesion. And then there are certain types of lesion like adherent alpha, displaced and avulsed labrum, glad lesion, and deep heel sac defects, which are more likely to recur. So the decision making in primary shoulder dislocation is number one, clinical factors. If it's a younger age group, high level of activity, there is a significant apprehension during the examination. If there is significant trauma, and if the patient doesn't have a generalized ligament laxity, these patients are more likely to recur. Then there are diagnostic findings. If you have a displaced and a significant labral lesion, if you have a deep heel sac, if you have defect in glenoid, then that means it may not be a first-timer dislocator. There may be subclinical instability and probably Hetal lesion. These are more appropriate lesions to intervene. And then there are patient factors. We always forget that patient should be willing for surgery. And usually it should be done in off-season and during vacation, not during the studies. So there is no fixed formula in which primary dislocation you will intervene, operate. By and large, if it's a young active patient who is impatient to wait, he is not in mid-season, he is not in mid-studies, and if there are significant lesions on MRI, usually offering surgery is a wide decision. So with time, we may change the way we execute, we may think, but the principles of the pathology and the treatments, they remain the same. Thank you.